Okay, welcome everybody to the PHU Clinical Academic Podcast. My name is Chantal Osler and I'm a consultant clinical academic, which is essentially a clinician who's also leading research relevant to their specialty. So I'm a physio and I specialise in prosthetic rehabilitation. And with me on our podcast journey is Marilyn Upton, a cardiology clinical academic nurse. And so this is the third in our Reviewing the Evidence series, which is aligned to the monthly educational hot topics and is designed to complement any upcoming study days that you might be aware of. And we'll be making a podcast each month, reviewing an article related to each hot topic, and we'll be accompanied by a PHU specialist clinician in the field. And so today we're doubly lucky in that we have two. So our topic is medicines management, and our lovely specialists are Karen Dutton and Marilyn Upton. Hello, ladies.
Hello.
So, guys, can you tell us a little bit about yourself and anything that you want to say about what's going on with regards to medicines management this month?
Well, you can start. So I'm Karen Dutton. I'm the medication safety pharmacist by background, and I'm the medication safety officer for the trust at QA Hospital Portsmouth. So one of the topics that we were asked to look at this month in particular in January was the patient safety focus month, involving controlled drugs and discharge medications, so TTOs as we call them. So what we've been doing all this month is trying to learn from incidents, raise awareness around the topic in general, and obviously this fitted in lovely, really keen to try and use this as an opportunity to look at research as well, because I did write a paper, it was quite a few years ago now, and it's really got me thinking again about how interesting it is to review a paper. And
absolutely,
we have learned in the past, but are very rusty.
Yeah, very rusty. Yeah, I know the feeling. So Marilyn, can you introduce yourself?
So my name is Marilyn Upton and I'm a nurse by background. I'm currently working in the patient safety team at Portsmouth PHU, looking at medication errors. And so I'm lucky I get to work with two really lovely teams, because I work really closely with Karen and the pharmacy medication safety team as well. So we're doing some training, quite a lot of training this month on TTOs and CDs, as Karen's already said. We have got some extra training sessions going on, but it's really exciting to do a podcast and to be involved in research again. So as Karen said, my research skills are a little bit rusty, but it's really good to be involved in reading articles again and to show to people that, in order to deliver best practice, they're quite easy to read, and then with experts there to help how we can use them in our daily work. So
fantastic.
Exciting.
So these guys have chosen a paper for us to review today, and the paper is titled Medication Discrepancies in Discharge Summaries and Associated Risk Factors for Elderly Patients with Many Drugs. Here is the paper. The link to that paper will be down below in the comments. And so this is a descriptive study. So we're going to use a critical appraisal tool to help guide us through the process. And as we know, as we've talked about before, there are loads of different tools online for critical appraisal, and we've been trying to use different ones each week. And so today we're going to use one called the Rapid Critical Appraisals Tool of a Descriptive Study, which is this one. And we will also put that link below so that you can find that tool. So before we start going through the appraisal process, we're going to ask Karen or Marilyn to give us a summary of the paper, just for anyone who hasn't read it yet. So are one of you happy to give us a little summary?
Okay, so I'm just going by the abstract at the beginning of the paper. So it describes that elderly patients are at high risk of medication errors at care transitions. That's a well-known thing already. The discharge summary aims to counteract drug-related problems due to insufficient information transfer in care transitions from secondary to primary care. So it's vital that that information is correct and transferred appropriately from one care setting to another. So the purpose of the study was to describe the medication discrepancy rate and the associated risk factors in the discharge summaries for elderly patients in particular. So by doing that, it's already cut out, it's focusing on a high risk group of patients.
Yeah.
So pharmacists collected random samples of discharge summaries from 10 hospitals, and importantly, this was in Sweden. So this is an international paper. So one of the things we're looking at is the differences between the practices here and how relevant it is to the UK.
Yeah, and that's really important so that we can think about whether the findings from this study are applicable to our settings. So yeah, really important to highlight that.
So medication discrepancies, both organisational, patient and care specific factors, and they split those up later, were picked up and noted. Patients are aged 75 or over with 5 or more medications. So they focus down even more on older patients with a lot, with a high number of medications.
Yeah.
And they say descriptive and logistic regression analysis were performed. So
we're all going to be absolutely terrified of, apart from Rosalind.
How is that to you to describe?
The rest of us are going to be like, oh my god! It's not that scary. But anyway, we'll talk a bit more about what that is as we go along.
Yeah, and I think for me it was quite interesting that they talk about care transitions, because even if our patients go to a different health facility, we still say we've discharged them, and for me it's quite an interesting term, because discharge is quite, and it's like the end of their treatment, isn't it? Whereas a care transition maybe is something we can
actually that's a really good point, because
absolutely
out of our problem. So they reviewed, or they included 933 patients, so it's quite a large number. Average age was 83. About half and half were 5% women. So medication discrepancies were noted for 38% patients. And unintentional addition of a drug was the most common discrepancy, including central nervous system drugs. Analgesics were the most commonly affected drugs involved. And the major risk factors for the presence of the discrepancies was multi-dose drug dispensing, which is something that we don't actually use in this trust. So that was an interesting finding.
Can I, just in case anyone else is watching this, can you explain what that is? And now this is the real physio of me speaking, because I have not a clue what. So the multi-dose dispensing.
So yeah, and I did look this up in relation to Sweden, because I think it's much more widespread over there than it is in the UK. That each time of day that a patient needs to take medication, they're in a little bubble. So they would have 4 or 5 tablets maybe in one little, a bit like a nomad or a monitored dosage system, I guess.
Yeah.
So in some of the hospitals over there, it seems like that's the way that they do things, which would be, I'm sure the nurses would be very keen for that to be.
That would be lovely.
That would be done here. So
individual nurses will be taking drugs out of all the different boxes. So much more complicated doing it here.
Yeah, they would just have one compartment for each patient each day. So that's quite a big difference actually.
Okay.
That kind of system anyway, and the electronic and the computer programs behind that, and an increasing number of drugs in the discharge summary, which probably would be surprising. If you've got a lot more drugs, there's more chance of error, I guess.
Yeah. Yep.
And and interestingly, a discharge from the departments of surgery. Yeah, which I thought was quite interesting.
Why do you think that was interesting? It's nodded there.
Sorry?
Yeah, so
why did you think that was interesting?
I think I found that quite interesting, because generally with surgeons, it's a lot more planned. So you've got a lot more idea. Even if people come in for emergency surgery, you've got more idea of when they're likely to be going home. So you've got a good overview of the length of stay. So more time to prepare really than kind of like non-surgical environments where there's a lot more investigations and things change quite quickly. So I was quite surprised by that as well.
And I think there's quite a few factors behind that. I don't know if I can talk about that now or later.
Yeah, go for it.
So with the surgery, they're not so focused on the medication. It's not their, they don't often change things or review medication whilst they're in hospital as much as on a medical ward, for example. So quite often you'll find that patients come in, have a procedure and go home with analgesics, but they won't be reviewing their blood pressure or any other kind of medical condition as such. But so the discrepancies, I was interested to see if it was because of a transfer of the wrong information in, or a transcription, or if they just if it was because of the level of staff that were doing the discharge summary, or if sometimes the pharmacist will think, oh well, it's let's focus on the medical patients because they've got a lot more changes going on.
Yeah.
So there's the balance of where you should focus your efforts as a pharmacist. As you focus on medical kind of wards where patients medications are being updated, reviewed, additions in hospital much more commonly than in a surgical ward.
Yeah, I was wondering about that with surgery, whether it had anything to do with the most common types of drugs, because analgesias were the most common types, weren't they, where there was errors, and whether surgery, because of what you've done to them, are more likely to have more analgesic drugs. I didn't know if that would have a link at all.
Yeah.
But all food for thought.
Yes, definitely.
Yeah. Okay, so anything else that you wanted to pull out of the study, of the summary?
I don't think so. I think it just says the conclusion was that discrepancies are common, and that they identified the circumstances in which it might be, good to have greater vigilance and increased to get increased safety for elderly patients at the transition of care.
Fab. So we're now going to go through and critically appraise this study, and so that we can get a bit of an idea about how much confidence we might have in the findings of that study and what we can learn from that. So if I run through the questions in the critical appraisal tool, question number 1 is, were the study's methods appropriate for the question that they were asking? So Rosalind, do you want to kick off with that one?
Yeah, sure. So I think we need to first describe a little bit better what a descriptive study actually is, because in order to know whether or not they use the right methods, you have to know what a descriptive study is. So if you think back, likely to when you were doing your education, whether that was 2 days ago or 15 million years ago, everybody is kind of familiar with that hierarchy triangle. So meta-analysis being at the top, RCT slightly below, then a bunch of other things that get a bit messy after that. Mm-hmm. So a descriptive study is different because what it's doing is it's describing a given phenomenon or event. So it doesn't necessarily have an intervention, but it doesn't mean you can't compare. Okay, so you can compare two different things, but they have to be something that you've observed rather than
something that you're adding,
something that you're adding
doing.
in.
Yeah.
Okay, so in that extent, what they decided they wanted to observe was whether or not the discharge summary reflected what the medical records would suggest that individual should have as their medication. So what they did is they went ahead and they got everybody's discharge summary, and then they also got they sat down in a group of people and reviewed everybody's medical records and came up with what they call a correct, and I use those the quotations purposely, a correct list of medications. And those were the two things that they compared. Was the pharmacist research team assumed or interpreted version of what the medication list should be and what the patient was actually discharged from. And then they did statistical analysis to say whether or not there were discrepancies. So that's kind of what they did. So 100% the tools they used, exactly what they should have used for statistical analysis.
And the method, so this is talking.
Yeah, with the methods, it was bang on.
Yeah.
To do that, to look at those two different things, and I couldn't really find any major holes in how it was designed as far as a descriptive study went.
Yeah. And so listening to what Rosalind described as as what they did as their methods, is that what you guys from reading it thought that they'd done as well? That's quite a good way to think about whether they clearly described the study, whereas if everyone thinks they did the same thing, so yeah.
I think I don't know if that comes in now, but I think I would have liked to have seen the data collection form.
Yeah.
Kind of.
Good catch.
Yeah, because there was so question 2 was, were the methods clearly described? And I think that I would absolutely agree. Me and Rosalind had a little discussion earlier, and I was like, did they do that or did they do that? And so there might have been a little bit of detail perhaps missing to help us to really understand exactly what they did. But generally, they described things really well. But yes, it was hard to. We didn't have any information about the instruments that they used to collect. And whatever their forms were that they devised to collect all this information. And that would have been quite easy for them to add in an appendix or supplementary information that we could then go back and kind of have a look at. And that gives us quite a lot of detail in their tools about the data, the actual detailed data that they're collecting. So yeah, that's really useful.
Yeah, I think particularly as if they're wanting this to be read and understood by readers in different countries as well that aren't familiar, because I think Sweden is relatively unique in the way that their health system works, and they don't have an NHS, so it's all run by private companies. So whether that makes a difference or not, I think it's really interesting to consider how that could have affected things.
I think that's a brilliant point, and I think whether you want to follow that underneath methods being appropriate or methods being described, for me, one of the biggest things that helps me know whether or not the study is of a high quality is exactly what you just described. So have they helped you as a reader understand the context, so what it's like for them locally, to know whether or not you believe in the processes that they went through in order to come to the conclusion that says, their conclusion was that the MDD system was not so great.
Yeah. I think especially whenever you're writing anything or reading anything, like I think often especially when you're writing, you just assume that people know what the NHS is, or like how it works, or perhaps how your country's health system works. And I think it's always benefit just having a bit of summary for just that background detail, so people can help to compare the context. So
that made me think about it, if we ever write something as well, that we should, describe that as well, because it might be a very different system. So I couldn't clearly understand how pharmacists over there are involved in the what we call a screening process. So we check the prescription before it gets sent to the GP. In as many cases as we don't see 100% of them, but we do. That is part of the process. And obviously they've got electronic prescribing, which we haven't got yet. We're just starting down that road as well. So yeah, that's a big difference at the moment in the way that these discharge summaries are dealt with.
So one of the things that also that I had listed was that they categorized, they made some categories for all their errors. And I wanted to check whether you thought as a pharmacist that those categories were appropriate, and that they hadn't like bundled a couple of things in together that actually would have been better to separate out and that could have had an impact on the findings. So whether you thought those categories were appropriate.
Were they the organisation?
And so it would be on the bottom of page 54, that there's kind of like the last 10 lines. It just kind of talks about the different categories. So things like they categorized it as incorrect details on mode and frequency of medication, the medication discrepancies, stop medications. So the different ways that they then categorized the different errors that they were seeing, whether that was appropriate.
I think that does cover. I think they're quite broad as well, so you can drill down further into those categories there. Quite unintentional addition of a drug was quite interesting. And the way that they described that a bit further down was that they seemed to be writing up things that a patient had when they were last in hospital, which was, I didn't know whether they were just taking a medication history from the last time the patient was in and like, oh, that'll do, rather than going back to the patient. And it doesn't really describe patient involvement in this and the counselling and the discussion with them at the bedside, or
yeah, and what happens as part of usual care. Yeah.
That's what I felt from reading it, that it was there was no kind of follow up with the patient, and like what you said at the beginning was that it's, you know, that's what the pharmacists were thinking by looking at the electronic systems.
Yeah,
that they could have spoken to the patients, but that would be a whole.
I smell a follow-up research study.
Yeah. But in general, I think
the answer to all research, critical statements, the need for more research. Okay, so if we go on to question 4, were all appropriate variables and interventions clearly described? And I think that they were. Did anyone have anything that they wanted to add about that?
So I think they did a good job at describing the variables. I think it was very clear the process that they went through, because their variables were the 2 different lists, as well as then how they categorized the discrepancies. And I thought those were they were fairly well described.
Yeah.
Without any real major issues.
Yeah. And I thought one of the things that I thought they did really nicely is that they had that points A, B, and C on page 55, and they've written like what their aims were of the study. And when I went back and looked at the data that they were collecting, they absolutely addressed those aims that were there. Like there wasn't anything that they were collecting that I was thinking, why were they collecting that? It was all, the data all seemed very much linked to the aims of the study, which was excellent. Okay, so so outcomes appropriate for the question, were the outcomes clearly described? I think we're saying yes. So question 7, was sampling clearly described? And so I think the comment that I wanted to mention just was that they did a really nice flowchart.
Yeah, they did. So again, for people who may not be used to research, or it's been a while since they've done it, this type of flowchart that is on page 56 of this article is actually a fairly standard procedure when reporting studies, because you need to be able to justify who you included, why you included them, but also who you excluded and why they were excluded. And this followed that process very, very clearly.
And that actually takes us on quite nicely then to say about were all the participants accounted for throughout the study. And again, actually, if we just pop back, that one thing we talked about last week when we prepared for this is this one patient that was excluded due to a data error of 87 drugs noted. And I was a bit like, is that uncommon to have 87 drugs? So, which obviously I've now found out that it is. So that actually, is that not a medications error in itself? So why was it not included? But they decided to exclude it, which is fine, but they didn't give us any information about that, about why they excluded it, about why they thought they had 87 drugs and why it was included. And the only point that it was mentioned was in their flowchart. So,
and I thought again, like your insight, Karen, is such a really interesting, especially with that they didn't really talk about, is now that they have this information about all these discrepancies and this poor patient who's taking 87 tablets, what then was done about that?
Yes.
What, you know, I mean, it wasn't the purpose of this study, but it would have been nice, like as a nurse, I'm sure you feel the same, Marilyn, is it was a bit like fingernails on a chalkboard. I was like,
it's full person.
Fix it. And there wasn't even just like a throwaway comment to say that part of their ethics procedure said that when they just found discrepancy, they would raise it to the clinical team. It was just kind of left hanging.
I was interested in the size of the dosette box for that
Suitcase.
So, okay, so if we move on to question number 9, was there freedom from conflict of interest? And so I think did anyone have any comments on anything they thought about conflicts of interest in terms of sponsors, funding, ethical approval?
So did you guys know where to find that on the paper?
Yeah. So
Yeah.
Find that.
Yeah, and it was really nice and clear on this one, wasn't it?
Yeah.
And it's quite a standard thing when you're writing an academic paper that you have a kind of a standard section that's about declarations of interest. So we can see that there weren't any declarations of interest or any conflicts. We also, there was a really nice clear statement in there, wasn't there, about their ethical approval?
Mm-hmm. Yeah, definitely.
Fab, so we're happy from that. So then we went on to question 10. Was the date range of the cited literature current? So what was the date range that was included? Did anyone look?
Yeah, that's what I was. That's what made me look at the literature, because I'll be honest, I don't think it's something that I would normally look at, but it ranged from I think 2002 was the oldest one.
Yeah.
And
so do you see that as too old? And if it's too old, why?
I don't know. I just think if you were doing that in the UK, I think the pharmacist roles has changed quite a lot over that time period.
And also, if you look at that paper, it's a systematic review. So chances are the findings of that review are from even older papers. So, yeah. But they did only use it in their background, and it was backed up by a second reference, I think. But yeah, I think it's like you said, like it's not something you necessarily would think about, is it? And actually, that's the first time I think in any of the tools that we've used that I've seen that question come up.
It is. So this is the third podcast we've done evaluating the evidence, and this is the first time we've seen it. And when I first read it, my knee-jerk reaction was, no one cares. Because this type of paper it's about the literature review. And I think but the more that I reflected on it, the more that I think actually it is a good question, because if you were reading a paper from 2019, and even though they just did a scoping review as part of the background, but all those references were from, 1970, I'd be like, well, you don't have a clue what's going on. I didn't feel that actually in the context that reference was being used, that oldest one, that it really mattered, because that was about actually giving the context around these sorts of issues. It wasn't saying, this is what's happening now, this is why it's important. It was more like, this is kind of where we're at and how we got here. So I think that question, like we've talked about before in other podcasts, like these tools are really useful, but they're not perfect.
Yeah.
I mean, I did note that it took them quite a while to publish it, because the data was collected in 2015-16, I think.
Yeah.
That's normal.
Yeah. Yeah, so it's about,
at that point,
years, wasn't it? Yeah.
So that's not unusual. So when you do research, depending on the type of research that you do, by the time you collect all of the data, analyze the data, that's usually a minimum of a year to 2 years, depending on how much data you're crunching and how much work you have to do that data.
And how much other work you've got to do around
that. And whether or not you're a clinical academic and doing 2 jobs at once, or doing it in your free time or whatever. But then even still, even if you were like Amazeballs and you collected your data, you had it all analyzed, you had the manuscript all signed off by all of your co-authors within a 6-month period, depending on the journal and how many times you get rejected, that process of actual publication can take years.
Yeah, I just had a paper published the other week, and that took a full year from when I submitted it to when it's going to be published. So yeah, crazy. So anywho. So if we move on to the results, so now I think just before we move on to the results, I think it might be useful Rosalind, prepare yourself.
Oh no.
For Rosalind to give us like just a little bit of a summary of what they did with their statistics. And because you were quite impressed with how they described their statistics, weren't you, and the amount of detail that they put in there. So, over to you.
So for the wide world of the internet, I must declare I am not a statistics expert in any way, shape, and format.
Get ready to write some rude comments on what
Exactly.
on what Rosalind's saying.
If I get it wrong, it's because I am interpreting
A mere mortal.
and a mere mortal. So do forgive me. So I think this is one of the stumbling blocks that a lot of clinicians have when it comes to reading a paper, is that statistics are math, and math is scary, and math is evil, and the devil spawned. And so you look at it, and all of a sudden it's a totally different language, and you're going, but what does that mean? I don't get it. Like, you've written about it, and it sounds like you know what you're talking about, but I don't understand it. So what they were doing in this study, okay, there's two major groups of statistics. You've got descriptive statistics, which basically are ones that you're going to be more familiar about. How many boys, how many girls, what's their mean age, things like that. Simple math, add them up and divide, okay? But then you've got more complicated statistics, which is more around the analysis of those numbers, okay? So what is not necessarily the meaning, but what is happening around those numbers, and is there any relationship between this group of numbers and another group of numbers, okay? Now, to do that, to compare two different groups of numbers, so you've got, like in this paper, you've got the pharmacist lists of medication, and you've got the discharge list of medication. In order to compare those two numbers, you have to make sure that they both are the same number, but then you have to look at the group of those numbers, so all 933, and you have to make sure that those numbers are behaving in a way that means you can use the test or the statistical tool that you want to use. So just like in healthcare, you wouldn't take somebody's blood pressure unless you were clinically worried about them every 5 minutes. So there are other signs and symptoms. There are checklists that you do as a clinician, as a nurse, that say, ooh, this person just like they stood up and they kind of waved a little bit. That makes me worried about them. Or if their heart rates are doing funny things, there's things that you go through in your head as a checklist that then say, okay, I need to do this person's blood pressure more frequently. Okay? Statistics are the exact same thing. When you collect a big lot of data, there are specific things that you need to look at with those data to make sure that you can then apply a certain test. And in this paper, they referred to things around, they use the term assumption, they use the term linearity, and sometimes in other papers you'll see the term they said normalization.
Rosalind's going to have sore fingers by the end of this.
So assumption is similar to what I was describing about a blood pressure. It's a checklist of things that you have to be able to prove that your data does, okay? And those are different depending on the test that you do, okay? I'm going to use the example of normality, which isn't talked about in this paper, but it's an easier one for most people to understand because it's a concept that gets talked about a lot more. So anytime you collect a big bunch of data, one of the first things you have to check into is this data normal? And what that means is if you put it on a graph, does it have a beautiful bell curve? Right?
Everybody has?
Everybody likes the bell curve. That's the way. Because if your data is normal, then that automatically means you only use a specific set of tests, which are called parametric. And all of that term means is it means you've checked to see that your data is normal. That's it. Why they have to use more fancy terms is because they want to sound clever and they want to confuse people. It's my own personal theory. If it's not normal, then you use non-parametric tests. The reason why I use that example is two of the tests they said that they were going to use is a chi-squared test and a t-test. Those two tests do the same thing. One is parametric, one is non-parametric. That's the difference, okay? So they can compare between groups and find out whether or not that difference is important or significant. The other major test that they do is something called a regression or a logistic regression. Again, it's a fancy term that says we're going to do a lot of fancy math and we're going to look and see. So we've determined that there's a difference between group A and group B. So the research pharmacist list versus the discharge list. There's a difference. Yay, we proved our theory. But now we want to know why. So in order to know why, what we have to do is we have to step by step look at all of those different variables to see whether or not any of those make a difference. So did it matter who wrote the discharge letter? Did it matter whether it was during the day, on the weekend, all of those other variables that they list in table 1?
Did it matter if the MDD machine did it or not?
Yeah, and that's how they're then able to say in the results, it was because of this, it was more likely if this variable was present, it was less likely if that variable was present. That's that regression that they did.
And we can see then in table 1 on page 57, if we're looking at table 1, it was the ones with the little a, the superscript little a, was the ones that they had found were statistically significant. And so that was the number of on-demand use drugs, the number of all drugs, multi-dose drug dispensing system, and discharge to a nursing home.
So those were the variables that would have been shown to be significant as to be the reason why there was a difference between pharmacy research list and discharge list, according to the math that they did. Now, whether or not that's important is a different discussion. That's just how they do the math. And in general, I felt, compared to a lot of other studies with way more complicated statistics, this study did a really good job in the method section of talking about making sure that their data did pass the assumptions. They did discuss linearity. They discussed several of the steps that if you are being open and transparent and doing more than just pressing a button on the screen of your data analysis system, that you should see in a paper. So I thought that was really good.
Yeah.
And the other thing that I thought was also really good is in their limitations section at the very end, is they put further qualifiers on it, because they said, even though we saw these things, our confidence interval on some of those variables was quite wide.
Yeah, especially when the groups were quite small.
Yeah.
Yeah.
So a confidence interval, do you guys know what that is?
Tell us, Rosalind.
Do you know? Go on, Karen, if you know, let's hear it. I don't want to be the only one being statistical.
This is like, when you say confidence interval nowadays, don't we all just think of Chris Whitty and him going on about confidence intervals on the BBC? So, go on, Rosalind, tell us.
Right, so confidence interval in a snapshot is basically a prediction based on your data that has to say if you were to observe this thing and this number. So if you were to observe a blood pressure of 110, and if you were putting it into this data, if that 110 falls within the confidence interval, hey, it means that your data fits within that prediction. So you are likely to have that number represent the relationship that was examined. Now, the problem with that is if the confidence interval is wide,
yeah,
anybody can hit that target.
Yeah, a lot of things would fit into it.
So just because you can fit something within a confidence interval doesn't necessarily mean that it's true or that it's significant if that confidence interval is really wide. But if that confidence interval is narrow and you still have your data within that interval, then that has a lot more weight to it. So again, it's not just about when you read a research paper and they're like, yay, we had a significance of a p-value of 0.0000006. That's not enough. There's many more factors that go into it. And if you don't know, ask a friendly statistician or a friendly person who knows a little bit more.
They're running around everywhere.
We actually have one.
We do have one at PHU.
We do have one, and he's very friendly, and he would
very...
love to help out.
Yeah, so he can be found in Lancaster House, and his name is Leon. I'm going to laugh now. He's inundated. But anyway, so if we go back and have a look at table 1, then we can see where the findings are. And actually, when we were, was there anything you guys kind of wanted to add about the findings? If there isn't, it doesn't matter.
Was there anything that particularly struck you that was interesting? It's okay if it's not, if there isn't.
I think it's interesting in fact that it's the on-demand use drugs. I would have wanted to know a bit more about that. I think that's just in relation to analgesics as well. Were the interventions more around analgesics?
Yeah,
only used when required. So whether that would have been a significant discrepancy in my mind, I'm not sure.
Yeah. So the other thing that you picked out, Rosalind, that you just mentioned earlier that we were kind of intrigued about was about discharge on a weekend versus discharge on a weekday. So I don't know if you want to say about.
The first thing to qualify on this is it wasn't part of the questions that they were asking, but I can't help myself when I see data. So I found it really interesting. If you look at, regardless of whether there was a medical discrepancy or not a medical discrepancy, depending on when they were discharged, there is a massive difference.
Yeah. So an 8% chance of an error on a weekend compared to a 92% chance of an error on a weekday.
So, but I don't think that it's fair to make that comparison on this data, because what we don't know, because they haven't told us, is that context again. So out of their sample, how many of the discharges were on a weekend? Because if there were only
by the look of it.
4 on the weekend, then actually if you had 4 discharges and every single one of them had errors, then that, when you put that in its relative terms, all of a sudden it looks way worse than how it's presented here. So again, it's just sort of like, to me, when I look at data, I just look at various things and it makes me think, okay, well, what was the bigger picture here? And it's probably where possibly publishing requirements, but also you can't look at everything in one paper.
Yeah, I mean, it looks like it's less than 10% were discharged on the weekend, so it's quite a small amount.
So it's quite a small amount.
Yeah.
But it still would be interesting to see on those subcategories how, like, the weight of it.
Yeah.
Comparison, rather than just putting it in terms of the whole sample, breaking it down a little bit more. But that's just me being data greedy.
Because if you looked at just that data, you'd be thinking, well, really, the best thing is to be discharged on the weekend.
Yes, yes, exactly. Which is really counterintuitive.
And I presume you can correct me here, but I presume that actually in real life isn't the way it is.
No, not at all.
Yeah.
It was similar, I found too, between the levels of seniority of doctors as well. And again, so I found it very interesting that, not surprisingly, the specialist who wrote the discharge letter had a lower discrepancy rate than the junior, but it wasn't that big of a difference, which I also found interesting. So with the ones with the discrepancy area, if you were a junior doctor, it was 137 or close to 40%, where a specialist isn't that much better. It was 80 at 22%. So it's not a huge difference, which kind of surprised me. But
so, because we kind of hijacked our podcast to have a little statistics lesson right in the middle, which is obviously very useful for most of us. I'm like going to go and get my calculator now, so I'll be like doing some memes, exciting stuff. We've talked about quite a lot of the different questions that came up in the results section. So I didn't know, was there anything else, because we've got about 5 minutes left, was there anything else that anybody wanted to raise about this study? Anything that that they kind of found? I generally thought their limitations was quite good. And they taught a lot of the things that we had discussed, they were already talking about in their limitations. Which was really good. And again, that final thing, which was just saying that actually this study is really about associations rather than causal links, was very useful. So is there anything else anyone else wanted to add about the kind of the discussion and the limitations section?
I think it's just really valuable to start to look at research papers again and think of all the questions that you've just been talking about. And I think this is a really hot topic at the moment. I mean, just following the this paper that we're discussing, there was a WHO challenge, the third global challenge of how to prevent harm at the on transfer of patients from different care settings. And it's so relevant to that that global problem. Another issue that we have now is that the GP practices here are having more pharmacy input, so they're kind of almost doing this work now, or starting to increase it. So we're getting feedback from GP practices about discrepancies.
Oh, okay.
So which before, but I don't know what their GP setup or primary care setup is in Sweden. To work out if the results of this have improved care for those patients, and whether processes over there have improved in terms of pharmacy input. And
that's a really interesting point. So, and it's a thing I thought I would just highlight as well. So every research study has what they call a corresponding author. And it's usually the first author, and they helpfully provide an email address. Now, being somebody who's written a research paper, who you put your blood, sweat, and tears into it, I can tell you with great assurity, they would love to hear from you and answer that question for you as to whether or not anything changed and provide more information. And in general, I would say if you are a clinician and you're reading a paper and you have questions about it, there is so much work that goes into this, but there is also so much work that doesn't ever see the light of day. So don't be shy. They're ordinary people. They're people like me. They're people like Chantal. They're people like you, Karen, who's written a paper. Email them. Ask them a question. You'll make their day.
Oh. You find out what happens to the patient with 87 drugs.
What happens to that poor person? So the kind of, I think the sort of take-home message from this study was that actually these medication discrepancies are incredibly common. That almost every patient in the study had at least one kind of discrepancy. And so do you think that those kind of findings would be similar within our settings? Do you think medication discrepancies are potentially that common here?
Oh yeah, I mean certainly all the discharge prescriptions that the pharmacists go through, I don't think there's one. There may be the odd one, but we do find discrepancies all the time. That's part of the day-to-day job kind of thing. And we are hoping that electronic prescribing will reduce that down, because one of the problems is the transcription from a paper drug chart to an electronic system with a drop down. So we are hoping that by just pulling that information across to a discharge summary, that will
improve.
So
is it possible that the really high incidence of medication discrepancies seen in this study, that they attributed some of that to the MDD system? That is it possible that it could be even higher here without a system like that?
Possibly. That's why I was, you know, I'd be interested to know more about that system and the electronic prescription and listing behind that, and how that is transposed over to the discharge.
So,
yeah. And perhaps thinking about studies that might have compared the performance of MDD systems versus nurses administering medication. Yeah.
and that's the thing too that I found was one of my overriding questions with this study as a design perspective, is although they used the discharge, they declared they used the discharge summary. What we don't know is how was that discharge summary informed? Because they did a very good job at telling us how they informed the corrected list, but we don't know for that doctor or whoever wrote that discharge summary how it was informed. So was it 100% reliant on that MDD system, or did they similarly try and do a similar system to what the pharmacist did? And so it's, for me, like you've said, like being a nurse on the wards and being a research nurse who's trying to track down when decisions got made about drugs and when, it can be a really complicated thing, because there's, even in Sweden, when they describe what they did, there's a million systems to look at, and they all have different dates and all have different access points. How do you know which is the more accurate one? And so for me, I don't know that it's all down to the MDD system. I think it's a lot about what you were saying, Karen, that interworking, and that how you come up with those decisions, and the time and how you focus your efforts within your pharmaceutical safety team to try and lower the incidence of these sorts of discrepancies so our patients are safe.
Yeah, absolutely.
Very interesting. Thank you for raising it.
Yeah, so thank you very much for both joining us and for everybody listening, joining us for the podcast. All of our contact details will be in the description below. And if you'd like any more information on either clinical academic careers or research in practice or medicines management, feel free to get in touch. And so we will see you next month for our next hot topic in the Reviewing the Evidence series, which is pressure ulcers. And we're going to drag him in from the sidelines. Jack, my clinical academic student who's been listening carefully, will be leading the podcast next time. So, thank you for joining us, and we'll see you next time.
Thank you. Bye.
Bye.